Sweetie Shaw. I am a pediatric otolaryngologist at Joe DiMaggio Children's Hospital, and today I am going to be talking about 22q11 considerations in pediatric otolaryngology. I wanted to state that I had no disclosures, and this is just a special interest of mine. I'm learning as I go, and happy to report some of the things I think about in our clinic. So these are some of my sources that I've used in the lecture. I'm happy to share if anybody would like. And today we're gonna see a brief overview of all otolaryngologic manifestations of 22q, but highlight some specific ones as a surgeon that we may need to consider, and just give a few recommendations on annual kind of checkups that these patients require from an ENT perspective. Hopefully we can also shed some light on how unique these individuals are, and the multidisciplinary setting that they absolutely need to get comprehensive care. Just to give a background at them, the more you will pick that up. Specifically, this child in the top middle picture, she has the most characteristic look out of all of these, but this picture is to show you there are many different manifestations. So just briefly, outside of ENT manifestations, there are definitely other occurrences. So they generally all have some sort of developmental delay followed by intellectual and learning disability. It may be to a mild degree or a severe degree. That is kind of the myriad of 22q, is that no two children with 22q are alike, and sometimes not even close to being alike. The myriad of symptoms and the severity of symptoms tend to vary greatly. But as they start surpassing toddlerhood into childhood, most of them tend to unfortunately have some sort of anxiety or ADHD disorders to varying degrees, and schizophrenia development in early adulthood has been reported up to 30% of 22q children, and reportedly higher, being noted in the last 5 years. They also tend to have immunodeficiencies, a lot of them having absinthymus, and decreased B cell and T cell productions. So endocrinology and immunology are two core team members in the multidisciplinary care team. A lot of them tend to have feeding problems that can be related to the oral abnormality of the velopharyngeal dysfunction, varying from any sorts of poor oral motor discoordination, and a lot of them have congenital heart disease. Up to 1/3 of 22q children have congenital heart disease. So those are some of the non-ENT manifestations I just wanted to highlight. So we'll get started into the meat of it. We'll talk about speech first, because although we may not surgically intervene on many of these children, this is a very important thing that ENT always should help follow. So most of them have some sort of language delay, whether it's from a syntax perspective, an atypical phoneme repertoire. There is some language complication in the formation of syntax, and that usually requires aggressive, repetitive, chronic speech therapy. The most classic thing that we probably all know about is hypernasality, a velopharyngeal dysfunction type of speech quality that in a 22q child is assumed until proven otherwise, meaning that we assume every infant with 22q has some degree of VPD until they develop speech and show us that they do not. Meaning that there's kind of a red flag screening always going on with every yearly or every 6-month follow-up with a speech screening in multidisciplinary clinic. And actually from a velopharyngeal dysfunction perspective, speech is super specialized. It requires a little bit of a fine-tuned ear to be able to pick up velopharyngeal dysfunction specifically. Hypernasality and VPD don't exactly go hand in hand. The umbrellas do overlap each other, but it's VPD is not as easy to pick up in a child with diagnosed or undiagnosed 22q per se. So that is always screened for. Now, from an anatomic perspective, they can absolutely have an actual cleft palate, complete or incomplete. That's more rare. What we see more commonly is a submucous cleft palate, or an occult submucous cleft palate. An occult submucous cleft palate, I'll get into it in a little bit, is essentially findings of a submucous cleft palate without the anatomic confirmation. Those are a little difficult to diagnose and treat. And then we have actual velopharyngeal dysfunction, which is dysfunction of the velar. Kind of the premise behind it is the underlying hypotonia of the palatal muscle is such that it can use a very wide pharyngeal flap and as high as you can go, meaning as high as possible in the posterior pharyngeal wall. And the reasoning behind that is because it's more of a static hypotonic dysfunction, making the flap as high onto the posterior pharyngeal wall as possible and as wide as possible without compromising too much of the airway tends to be give the best results in 22q children in terms of speech. So really quickly, this cartoon is not 100% accurate of what I do, but it gives a general idea. Is, looking here in the mouth, in the posterior oropharyngeal wall, make a U-shaped mucosal flap all the way down to the fascia. And then we flip this flap into the palate, essentially creating a sandwich. There are a few common methods used. I think some people simply split the palate in half and sandwich it together. And some people separate the mucosal layer and the muscular layer of the palate and really cinch and tent it in. This cartoon seems to be kind of a hybrid of that. It doesn't really show the splitting of the mucosal and muscular layer. And then there are others that will tack the flap right onto the palate without really any incisions. I think that technique is widely not used anymore. And then as you look down here in D, the lateral pharyngeal mucosa is then reapproximated as best as possible, and usually this heals very nicely. As you can see, there's usually an inferior edge opening because of tension purposes. Usually the child recovers similar to a tonsillectomy in terms of pain and difficulty swallowing. It can be quite tough for the first 3 or 4 days, and a lot of them require post-operative inpatient admission. So this is kind of the workhorse of speech surgery in VPD-22Q. Now, just to change gears towards the occult submucous cleft palate, a submucous cleft palate is identified, speech is evaluated, and the need for furlopalatoplasty is determined, and then the furlopalatoplasty is done, and usually speech improves. In the occult submucous palate, it's a much more tortuous road, so to say, where there's no visual anatomic abnormality, but in the speech evaluation, there certainly is VPD consistent with some sort of submucous cleft palate when there's no anatomic dysfunction. This is thought to be due to an inherent weakness of the levator muscle that is theoretically thought that every 22q patient has, but is manifested much more severely in one versus the other. And this is just to kind of illustrate the levator muscle right here. And the intervention for this is still possibly a furlopalatoplasty versus a palate lengthening procedure. There are many tests that speech therapists do, including video fluoroscopy and nasometry to help determine this. including our nasal endoscopy procedure in conjunction with ENT, and sometimes still we don't have an answer. And I wanted to just highlight a speech MRI for occult submucous clefts, or assessing the levator muscle. This is a fairly new technique that's not standard everywhere, but that I think has a large role in 22q children. It's a specific type of MRI, and a specific type of cut that is done through the oral cavity, and an actual program is created to identify and zone in on the levator muscle and take measurements. And I've just given you two pictures that have obvious differences. Here you have the levator muscle in a thin U shape, and then we have a thick levator muscle in a V shape. This one clearly could benefit from some intervention. So these speech MRIs are done without sedation. They take about 15 minutes. Actually, the University in Florida, Orlando, has created a nice guideline on how they prep children all the way from child life and bringing them into the MRI suite, and how they actually do speech samples during the MRI to get the appropriate movement of the levator muscle. And although done in a small sample, there seems to be great success in its use. So we're trying to actually implement that in our hospital system. Unfortunately, COVID delayed the two hospitals conjoining and moving forward. But this is something to kind of know about, and know that there are some speech considerations in 22q that still evade us. And there's a lot more to learn about these 22q kids and their speech. And this is just a basic furlopalatoplasty. In the interest of time, I won't zone in on it too much, but we're making one mucosal and one muscular flap, and essentially double opposing them into a final Z-plasty. So you see the levator muscle is not aligned properly, and after the Z-plasty, crisscross applesauce as you're supposed to. And this also lengthens the palate, although this cartoon doesn't illustrate that. So for levator dysfunction, this is the appropriate surgery, although hard to identify when not an obvious submucous cleft. So, the speech considerations in 22q, the things to know are that we do need specialized VPD speech language pathologists specifically familiar with 22q to service these patients appropriately. And even the care provider, even though we're not utilizing all these, we should be aware of all these speech modalities utilized before resorting to surgical repair, whether you're the one repairing it or the one, assisting in the decision making from a airway standpoint. That there's nasal endoscopy, nasal video fluoroscopy, specialized speech therapy, nasometry, many other speech quality scales that are utilized to kind of determine the end game. Another thing to know, not really in my world so much, but the fact that these adult 22q patients have even less comprehensive care than the pediatric patients. They need the most psychiatric help, which is hard to come by. But in addition to that, these 22q adults do have difficulty functioning as independent adults across the board. Some do better than others, but they still can end up having residual VPD and articulation errors even after surgical intervention. And so far, we've seen that about 8% require revision out of the ones that seek help, basically. So it doesn't end in childhood. That's the bottom line here. Next, we'll kind of focus on airway. This is just a classic textbook board question of the glottic web. You automatically think of 22q. It's actually not as high incidence of a finding as is other airway lesions that we commonly see regardless in the pediatric otolaryngology world. Ironically, tracheomalacia is the most common airway finding. Now, this graph is taken from a paper that that had the largest cohort of 22q patients studying all the airway anomalies. So that's why I posted it. Pretty consistent with most of the other airway reports on smaller scales. Tracheomalacia and laryngomalacia are the most common airway findings in 22q children, followed by subglottic stenosis and bronchomalacia. As you can see, laryngeal web was present in less than 15% of patients and usually identified in the first month of life. And then we have other more rare findings. And out of this cohort of 74 patients, 22 of them ended up requiring a tracheostomy at some point in life, usually within the first 4 months. And out of 22, 20 of them had congenital heart disease. So just to illustrate, the congenital heart disease is very common in 22q kids, and the most common congenital heart disease is usually a VSD or tetralogy of Fallot. They followed, most of them had tracheostomies for over 5 years, and unfortunately one of them deceased, and most of the other ones that had prolonged tracheostomies that were mostly with tracheomalacia in the setting of congenital heart disease. So although the airways are may be treated the same as any other child, the perioperative considerations of hypocalcemia and cardiac considerations are definitely at the forefront. So, in terms of 22q, even, the most important thing is to be screening for airway problems outside of the routine snoring and rhinitis questions you may ask. Voice quality is a large thing in 22q that's really understudied and highly variable. And in the first 3-4 years of life, that's really not the focus, because people forget about it. The focus is, are they hearing well? Are we getting them the ear tubes or the hearing aids they need? Are we getting them the speech services? And then focusing on their other body systems. But the voice quality can be affected in the same way that the oral muscles are, theoretically hypotonic in some sort of way. There are theories about that with the vocal cords, but there's just not enough studies in older or adult patients and with 22q to be able to confirm that. But the most important thing to know in the infant and toddlerhood age is the impact of airway lesions on speech, swallow, and sleep apnea. And those are the most important things. You have to know how and when to be aggressive with treating these airway lesions, because growth is very important. And actually 22q kids have a separate growth chart because their growth is lower or slower than the average growth of an otherwise healthy child, normal child. So these things are really important. So your 22q team or the pediatrician even should be knowing about this 22q specific growth chart. So how and when to intervene on the airways certainly plays a role in the whole clinical picture of the child. Now we'll talk about sleep a little bit. Sleep in 22q is very, very intertwined and very complex because of the behavioral issues that come with 22q and the high incidence of parents that also have 22q who already struggle with these children, because as they start turning 3 and 4, the behavioral issues just start, rapidly progressing. And with in a parent with 22q, that can become quite difficult to maintain. So just that alone affects the sleep of 22q children. Then it's very well known that there are higher incidents of obstructive sleep apnea reported in children with 22q, and TNAs are performed in over 90% of those children. and that's not what I'm really here to talk about. That's straightforward, as we all know, in a sense. But really, the sleep patterns and the characteristics of the sleep of 22q children is really understudied. And then there's a separate, sleep consideration for OSA in children who undergo speech surgery, such as pharyngeal flaps or sphincter pharyngoplasties, as those surgeries obviously can increase sleep apnea or sleep disordered breathing and worsen it. And then, I'm not going to go into this in this lecture, but there's certainly consideration for a staged tonsillectomy adenoidectomy prior to performing a pharyngeal flap, even in the absence of symptoms. I think that, most centers are somewhere in the middle. Some centers remove as a staged procedure no matter what before the pharyngeal flap. Some centers screen clinically if there are any symptoms, historically, if there have been, if the child's overweight, then we consider the staged procedure. And then there's the other school that really doesn't. And a lot of these kids don't have sleep studies pre-pharyngeal flap, especially if it's a non-ENT surgeon doing the procedure, if they don't have ENT support. I have seen a lot of flaps done without the proper airway workup, resulting in CPAP use afterwards. So from a pharyngeal flap perspective, an adenoidectomy should be performed prior to, so that the pharyngeal flap can be properly resected. So anyway, that's a side thing that we're not going to address here in this talk. But I wanted to just talk about this study that looked kind of at the sleep patterns of 22q children. And interestingly, the literature review that they performed showed that sleep apnea, it has been associated with atopic, autoimmune inflammatory disease and reflux. The impact that we don't know about, and these children go through all the time, is the impact of multiple surgeries, multiple hospitalizations, psychiatric illnesses, diagnosed, undiagnosed, treated, not well treated, and and the presence of congenital heart disease. All of this compounds into the quality of sleep. It's not just as simple as obstructive sleep apnea, remove the tonsils and adenoids. So in this study, they did the sleep CSHQ survey with parents of 22 children with 22q. 41 patients responded. They were not all US patients. They were actually international patients as well. And all patients had already had either some sort of surgical or medical intervention to try and address the sleep problems. And what they found was that the parasomnias that were highly reported were associated with developmental delays, and that there was a high association with the parasomnias related to eczema, specifically eczema in the 22q kids. So basically, they brought up the issue of these children need to be screened for sleep quality much earlier, rather than just the otolaryngologist screening for sleep disordered breathing in the clinic. So we've actually changed our practice in our clinic and started doing a sleep survey at every visit. It can become a little overwhelming for some of these parents, especially if they have 22q. It's a lot of information for them to keep track of within a multidisciplinary team. But we try to get them with the survey once a year after age 3. And it has seemed to help if you have access to appropriate sleep medicine physicians. We'll switch gears now to otologic manifestations. The last two are fairly short, so hopefully you won't be falling asleep here anytime soon. But the most common otologic manifestation is otitis media. Why? I think the thought is that there may be a higher incidence of eustachian tube dysfunction because of the known kind of inherent dysfunction of the palate. They also are immunocompromised to a certain degree. A lot of them have low T cell formation, and a lot of them have absent-thymuses, and so it's kind of a multifactorial reason as to why otitis media has been reported in wide ranges, but pretty consistently at least 30% or higher. And and the prevalence of mild hearing loss unrelated to middle ear disease. So that's kind of important, is that mild conductive hearing loss is present in about half of these patients. These patients don't routinely undergo brain imaging or temporal bone intra-arterial canal imaging routinely unless we're looking for something specific. But there was one paper that did look at that, and they actually found incidental inner ear abnormalities of 12% in their cohort of 47 patients, which was interesting because a lot of the findings were semicircular canal abnormalities that would translate into imbalance. But again, I don't think that, there's just not enough literature to evaluate the presence of balance dysfunction in 22q adults or older children. And I'm sure that there are more prevalence than we know of. Interestingly, there is a low prevalence of sensorineural hearing loss in these children. And there's no evidence to suggest that there is any sort of progressive hearing loss trend that's ever been noted in the conductive component. Actually kind of unclear why there's mild conductive hearing loss is present in many of these patients, because many of them don't end up in the studies didn't have CT temporal bones. All of them did not. But what this translates to is, annual audiogram at least in a multidisciplinary clinic, and ENT follow-up, even in the absence of reported ear symptoms, is important because of the high incidence of speech difficulty, behavioral issues, and possible academic difficulties that these children face. So lastly, we'll talk about the head and neck, which is kind of fun but rare. The most common board question sort of thing is the medialized aberrant carotid arteries, which you want to screen for if you're operating in that area, most commonly because of pharyngeal flaps. Every patient undergoing pharyngeal flap with 22q should absolutely have an MRA. Very rarely does the actual surgical course change, in which you cannot harvest the posterior pharyngeal flap, which is important for obvious reasons. In which case, posterior pharyngeal wall augmentation can be performed, or other considerations of sphincter pharyngoplasty can be done. But that's kind of becoming a standard kind of recommendation. It's not published anywhere, but that should be done. In tonsillectomy, a preoperative MRI is not routinely necessary, although there will be no double questioning if there were. And the other thing perioperatively is the transient hypocalcemia in the absence of any hypoparathyroidism or any parathyroid disease. The thing is that they always have a latent hypothyroid state, a hypoparathyroid state that can be essentially triggered in a stressful situation such as surgery. So all patients undergoing some sort of major surgery, to me that means anything more than ear tubes, should be getting a postoperative calcium check just to identify early post-op hypocalcemia. And then thereon afterwards, if normal, should just be checking for clinical symptoms of twitching, Schwastek sign. Nobody's going to do a Trousseau sign at home, but these patients are counseled appropriately to look out for that. Interestingly, there are no relations known to thyroid malignancy in 22q. And again, another fun board question is that they have absent thymus in about 20% of these population. And sometimes the absent thymus during a cardiac surgery is noted, and that's what triggers the 22q testing, and all kinds of fun ways to identify. This is just an intraoperative picture of this medialized carotid of the right side. This is not my patient, but I've definitely seen some really fun ones. And this is just an imaging showing bilateral medialized carotids, which you could not harvest a pharyngeal flap in this patient if you needed to. So imaging is important. Postoperative calcium check is important. And knowing that if absent thymus is thrown around on the patient's chart, the cardiac surgeon mentioned it, or an in utero, that triggers 22q testing. So in all, I have like 20 seconds left, but the best care of these patients is a multidisciplinary care in which people are, privy and, used to treating these kids, annual audiogram, continued dynamic speech evaluation, and, awareness of these manifestations key in preventing